Good afternoon, everyone, and welcome to week 4 of our APPs in Urology Symposium. Today we have a fantastic lecturer, nurse practitioner Heidi DiGennaro from Cleveland Clinic, who is here to talk to us about the medical and dietary management of kidney stones. Super excited to have you. Just a note on our program, so we're about half through our program so far. If you've liked what you've seen, please continue to help us spread the word to your colleagues and your programs. We are obviously geared toward advanced practice providers, but we're open to all medical students, residents, fellows, even attending physicians, anyone who is interested in listening to what we have to teach and to present. We have a few more weeks in our pre-scheduled programming, and so we're going to work through those, and then if you've liked what you've seen, we can hopefully keep this program going. In this next week or so, we'll be sending out some surveys if you are interested in responding about how you've liked our program and where you've heard about us, just so that we can get some feedback and use it to help direct our future programming. All of our webinars, including this one, are recorded and can be found on our YouTube channel. If you go to YouTube, you can search for APP Symposium and find our channel. You can subscribe to it to get notifications on future recordings. You can also follow me on Twitter at EuroPA_SD, or you can follow at UCSD Urology in order to get the links for both the recordings on YouTube as well as for this and all future registration links for our future Zooms. At the bottom of the screen is the Q&A button. During the lecture today, you can go ahead and ask questions at any time. I am going to save those questions to present to Heidi until the end of the webinar. However, you can use it along the way to ask your questions, or if there's any problems with audio or video, if you can't see something, go ahead and put that comment in the Q&A box so that we can go ahead and fix it for you. And so without further ado, I'm going to go ahead and introduce Heidi. So Heidi DiGennaro is a certified family nurse practitioner and a certified urological nurse practitioner who works at Cleveland Clinic. She has worked primarily in kidney stone disease for the last 7 years in a busy stone clinic with Dr. Manoj Manga, who is now chairman at UCSD, as well as 3 other surgeons. Heidi received her Master's of Science in Nursing from the University of Cincinnati. She is also trained with Dr. Christine Peniston at the University of Wisconsin in the metabolic management of stone disease. So thank you, Heidi, so much for being with us today, and take it away.
Thank you, Rachel. Thanks for the invitation, and thank you all for joining us today. So we're going to talk about medical and dietary management of kidney stones. So I have no disclosures first, and then our objectives today. So upon completion of the presentation, you'll be able to identify several risk factors that contribute to kidney stone development. You'll be able to prescribe appropriate labs, testing, and imaging as suggested by the AUA guidelines. You'll be able to identify a few kidney stone dietary risk factors, prescribe appropriate interventions for hypercalciuric, hypocitraturia, hyperoxaluric, and hyperuricosuric patients, and then describe some general dietary and lifestyle tips regarding kidney stone prevention. So according to the NHANES, the prevalence of kidney stones has increased 70% since 1994, with nearly 1 in 11 individuals in the US being affected by kidney stone disease, according to the AUA. Kidney stones are a chronic condition requiring routine follow-ups and continual adjustments to treatment plans in order to prevent or lessen exacerbations. So there's several metabolic and environmental risk factors for kidney stones. Age is one. It's more common to have your first stone event between the ages of 20 and 50 years of age. Sex is more common for men, 2 times more common for men to develop stones than women, but women are slowly catching up to the men. Race, it's more common for white Americans to develop stones than African Americans. Your activity level can play a role. People who are bedbound, wheelchair-bound, they are at greater risk. And also those who do excessive, like extreme sports, because you're losing a lot of fluids through sweating, that can increase your risk for stones. Climate can play a role, so those who live in hotter climates, and we often see more stone events during summer months. Genetics, if you have a family member who has history of stones, then you have a greater risk for developing stones. Then there's certain disease conditions that can increase your risk. So anybody with any GI diseases like Crohn's, colitis, IBS, people with hyperparathyroidism, diabetes, sarcoidosis, osteoporosis, various kidney disease, obesity, and gout can increase your risk for stones. And then people who've had certain surgeries. We're seeing a lot of bariatric patients who are now developing stones, people who've had colectomies, or any procedure that affects the digestive tract that can increase your risk for stones. And then if you're taking certain medications, that can increase your risk. There's not many out there, but some medications can increase your risk. So if you're taking carbonic anhydrase inhibitors, any protease inhibitors, or if you're taking a lot of vitamin C supplementation, or if you have too much vitamin D or not enough vitamin D, that can be a risk. So kidney stones develop as a small crystal-like material that can gradually build up into a larger solid mass. Your urine normally contains chemicals that can inhibit these crystals from forming, or it can maintain, or it keeps the crystals small enough so that they can pass through the urine without causing you any problem. The issues happen when crystals combine with other crystals, they begin to form these stones. Instead, they can stick to the lining of the kidney or settle into little nooks and crannies where the urine can't carry them out. And then they just kind of build up until they start to cause you some problems. So there's 4 major types of kidney stones: calcium stones, uric acid, cystine, and struvite, with the majority of the stones being calcium-based, but 80% being calcium oxalate and calcium phosphate stones. And here are just some pictures of kidney stones if you haven't seen them before. So you have a patient who's been identified as a stone former. So now what do? So the AUA has laid out some medical management. They recommend a detailed medical and dietary history. They recommend blood work. So you want to check serum parathyroid hormone, serum calcium, uric acid, and vitamin D levels. If you have a stone available, not everybody catches their stones, but if you do happen to have a stone, I would recommend you get that analyzed. If you don't have any images or any recent images, an ultrasound, a KUV, or a CT scan. The CT is the golden standard, but not everybody has that available. And then we recommend some metabolic testing. So 1 or 2 24-hour urine collections. I usually use Litholink, but if your hospital has a 24-hour testing, then you want to make sure that it includes total urine volume, pH level, calcium, oxalate, uric acid, citrate, sodium, potassium, and creatinine as part of your scan. So why obtain a diet history? Well, a diet history, you can identify their current dietary practices. You can identify some nutritional related problems. It provides a baseline so that you can monitor changes over time. You can identify alternatives, food alternatives for the patient, and then it helps develop a rapport. There's several ways you can go about gathering diet history. There's food diaries, 24-hour diet recalls, food frequency questionnaires, food intake records, nutritional assessments. If you have a dietitian on staff, they can also help you gather that information. There's many of these sources are available online. You can download them, have the patient fill it out ahead of time. A lot of times I find you just don't have the time, so a simple 24-hour diet recall that I do during the visit is sufficient. So the role of diet. Diet is one of the several factors that can impact the risk of developing stones. Diet's been shown to influence your urine composition and can modulate the risk of kidney stone disease. There's limited research available, but short-term clinical studies have shown evidence regarding the role of diet and its influence on stone formation and prevention. Diet modification can decrease stone risk factors, it's inexpensive, and it's a safe therapy compared to drugs and surgical treatments. So I have a sample patient here. So I have a 73-year-old male. He's retired with primary medical history. He's got some BPH, COPD, was a former smoker. He's got a history of making a variety of stones, which is not that common, but with everybody's diet these days, we see just about everything. So this gentleman has had uric acid stones, calcium oxalate, and calcium phosphate stones. Currently, he's happy, he's stone-free. He's had normal serum uric acid and parathyroid levels. So you can see from a recent 24-hour urine test, this is what we get from a Litholink report. You can see from the little diet recall that I did, he doesn't do much for breakfast. He drinks these Bay drinks or Bai drinks, which is like a fruit-flavored water. He snacks on some fruit, like a banana or an apple here and there. He usually makes a sandwich with lunch meat or Caesar salad. And this particular day, he had nachos. He made a big plate of nachos, he said, some with meat and some with refried beans, salsa cheese. So you can see the variety of drinks that he consumes on certain days, and then you can see his medication. So for us, he's taking allopurinol, hydrochlorothiazide. He's taking some Proscar and tamsulosin and potassium citrate and vitamin B6. So from the 24-hour urine test, we could see he's got some things that are out of normal limits. So his uric acid, calcium, oxalate. His urine volume is good. It's at 3.5, which is not, we don't see that too often, but he's drinking excellent. And his sodium is a little high. So what are we going to tell this patient, or how can we counsel this individual? So first we'll start with the high uric acid levels. So why does he have a high uric acid? His blood uric acid levels are normal. So is he consuming a lot of purines? Does he not consume enough fruits and vegetables? Is there a genetic link? Possibly. He doesn't have a history of gout, so it's not a genetic link. So we're looking at diet, his high animal proteins and not enough fruits and vegetables. So what I would recommend for his uric acid levels, I would counsel him on reducing his flesh proteins. So we're looking at chicken, beef, pork, and fish. So you can see from the chart above, a lot of people think that they can just cut out red meat and that will be fine. But if you look from the chart, fish actually has more uric acid than beef. So, and I know a lot of people are moving from red meat to more fish to help with cholesterol, but they have to do some balancing if they have some uric acid issues. So something else that can affect uric acid, I would counsel him on reducing his fructose, so that his little bai drink that he really enjoys does have fructose in it. So he may want to consider switching to more water or diluting that fruit juice. So I know it's hard to get people to drink, and when people find something they like, I don't want to dissuade them from drinking it, but maybe they can reduce it or dilute it. And then decrease alcohol. He doesn't do a whole lot of alcohol, so I wouldn't stress that one so much. Maintain healthy body weight. He was a little overweight, not terrible, but certainly everybody could use some exercise in their life. So I always encourage that with all my patients. And then fluids. He surprisingly had a good fluid intake, whether that was his normal or if he just pumped it up because he knew he was going to see the doctor. You have to question that sometimes. So I always preach fluids, fluids, fluids. Okay. And then medications. He is on some of these. He's on allopurinol. You can also prescribe Uloric for people. Potassium citrate helps reduce, helps balance the acid. If they can't tolerate potassium citrate, sodium bicarb can also be used. So he also has high urine calcium. So why would people have a high urine calcium? So you could see some of the reasons here. Bone loss, he doesn't have osteoporosis. Excessive salt, we did see he did have a high sodium level. Vitamin D deficiency, his vitamin D was normal. Malabsorption, he doesn't really have that issue. He doesn't have any GI issues. Low fiber intake, probably he could do better with fiber. His parathyroid normal, and we know that he had a high acid load with his uric acid. So how would I counsel somebody with a high urine calcium? So you want to concentrate on reducing the salt. Sodium affects the absorption of calcium. So low sodium diet is preached to a lot of people. We have a lot of processed foods in the American diet. So certainly everybody can take the time, read food labels, and try to choose some options that are low sodium. So I encourage my patients to try to consume less than 2,000 milligrams a day. Some people have to go a little bit firmer and try to get below 1,500. So there's a lot of sodium in our diet these days. And let's see, calcium, you want to make sure that patients are intaking a sufficient amount of calcium. So people think, well, I have a high urine calcium, I have to cut back on my calcium, but that is not true. You still need calcium. You need 2 to 3 servings of calcium per day. But what's happening is the sodium is disrupting that absorption. So don't give up the calcium in your diet. Proper acid load. So that's, again, reinforcing, watching those flesh proteins, that fish, beef, pork, and chicken. Okay. Fiber is important. We could all use a little bit more fiber in our diet too. So increase that. Fluids, again, I preach that to everybody. And the medications that can help with high calcium is thiazide diuretic. in various forms. Sometimes you do have to supplement the potassium, so you do want to check blood work after that, so some Cater if needed. Fish oil has been shown to help with some of the calcium reuptake, and vitamin D, because that's going to help with the calcium absorption. He also had a high oxalate level, not terribly high, so I don't think I would focus so much on this because he's got other issues that I would like him to concentrate on. But oxalates are a big one because a lot of people make calcium oxalate stones. So oxalates, if you're not aware, it's a naturally occurring substance. It's found in plants, animals, humans. Chemically, it's in a group of molecules called organic acids, and our bodies just contain oxalates. Our cells routinely convert other substances into oxalate. So you have a lot of people probably now because of COVID, they're pumping their bodies full of vitamin C, thinking it's going to help their immune systems. But too much vitamin C, the body actually converts that into oxalates. So we may be seeing a lot of calcium oxalate stones after this COVID crisis, but hopefully not. So some other reasons why you would have high oxalate. So excessive vitamin C, you can just have a microbial imbalance. Some of us just are born with the right microbiome in our gut to handle oxalates, and some of us just don't have it. If you're consuming just tons of high oxalate foods, possibly, or like the GI tract is just not absorbing the right components, and that's why you have too much oxalate. So how I would counsel somebody on a high oxalate. They used to say, preach low oxalate diet, cut out all the oxalates. But if you look at the oxalate food lists that are out there on various forums on the internet, oxalates are in tons of healthy foods. So you don't want to tell somebody not to eat spinach or berries or vegetables because we need those because it contains other nutrients. So I don't necessarily tell people to stop these foods. And Dr. Peniston put out an article in the recent AUA newsletter, and she also mentioned this in the AUA conferences this past weekend. You don't want to discourage oxalates. You need oxalates, but what you want to stress is pairing them with calcium-rich foods. Calcium-rich foods do not have to be dairy because there's a lot of dairy-sensitive people out there, but you may have to be creative and have to search for some calcium-rich foods that balance with the vegetable. So I don't tell people not to eat anything. Certainly in moderation, you don't want to be consuming tons of chocolate because that has it. But, you know, I don't despair anybody from eating a piece of chocolate every day. So increase your dietary calcium, certainly, because that's going to be at the natural binder to oxalates. So try to have something with calcium at each meal, and that calcium will bind with the oxalate at that meal. Calcium it binds with it and kind of directs it towards the GI tract so that the calcium will go out through whatever calcium is not absorbed. Calcium will go out through the stool rather than having this calcium through the urine. Probiotics can sometimes eat away at some of the oxalates, again, directing it through the stool rather than through the urine. Again, fluids for everybody. And then some medications, vitamin B6. There's some studies that show that can help curtail oxalate levels. Fish oil, and I mentioned the probiotics. So this gentleman had a high sodium, and I hear this all the time. Well, I don't eat any salt. So if you look at the diet, if you look at his diet, he had a whole plate of nachos, refried beans, salsa, cheese. I mean, that is loaded with sodium. He had a Caesar salad, dressing. So if you see from the pie chart here, a lot of their salt is coming from processed foods. Very little is coming from the table salt. So you have to watch, you have to read food labels. You want to encourage fresh over frozen or boxed, or anything prepared is going to have a lot of sodium in it. So again, you want to try and stay under 2,000 milligrams a day. DASH diet stresses this too. Certainly a lot of people in America have hypertension, so they should be watching their sodium to begin with. But this is, again, just stressing another reason, the benefits of low salt. So let's see, again, encourage more fresh foods. You want to try to encourage shopping on the perimeter rather than the middle, because that's where they put all the bad foods for you. The fresher foods are on the perimeter. And then fluids. Can't preach that enough. So this is back to that gentleman. So we talked about, gave him a lot of dietary information. We're also going to have to adjust his medications. So what I would do, I would increase his allopurinol from 100 to 200, and I would check his liver function tests in about 2 to 3 weeks. I would increase his hydrochlorothiazide, maybe a half a dose to 25 milligrams a day. You want to check his potassium in about 2 to 3 weeks. Monitor his blood pressure. If he's interested, he could try adding some fish oil because he's got quite a ways to go. His calcium is at 498, and we would like it to be under 250. So, so certainly whatever he's willing to do, certainly cutting down the salt and increasing his medications, hopefully that'll put a dent in that number. Increase the B6 from 100 to 150. And then I would have him maintain his potassium citrate where it's at because his pH is at a good 6.2. And we need to combat his uric acid there. So, and then anytime I do a medication adjustment, I like to recheck the 24-hour urine in 3 to 4 months. So again, it's just monitoring, adjusting, okay? Our next patient, a 49-year-old female, she's a nursing director. She's had a history of IBS, GERD, and she had a stroke. She has a history of calcium phosphate stones. She currently has stones in each kidney. She just recently passed a stone. So she was all eager to do another 24-hour urine test to figure out what else she can do. So you can see from her 24-hour results and then her diet, she admits she does not drink very much. She's on the road a lot for her job. You can see she eats fast food, a lot of takeout, a lot of kind of convenience things. And then her medications, she's on potassium citrates, some medications because she was just passing a stone, but not a whole lot for stone-wise. So what we found, her pH is high, which we normally see with calcium phosphate stones. And her citrate's a little low. Her volume is her biggest issue. She's not drinking 1.2 liters, but her sodium is okay. High end of normal, okay? So what I would do, and this is the majority of my patients, is what we're talking about, is increasing your fluids. It's the #1 risk factor for stones. Too little urine produced in a day can lead to a concentrated urine. Concentrated urine forms crystals. Crystals leads to stones. So the average person produces about 1.5 liters of urine, and we're recommending 2.5 to 3. So you almost have to double what the average person is consuming. Water, obviously, is the best thing for you, but certainly anything you drink is going to help make urine. The more urine you make, the better you flush out the system. And not only drinking well during the day, but we also suggest drinking before bed. I know people don't like to interrupt their sleep, but your kidneys are constantly working. So if you can get up at least once through the night, empty things out, and then drink another glass of water, you can reduce your stones risk factors by 70%. So drink. Okay, certainly even coffee and tea in moderation is okay. You don't want to do too much caffeine. You don't want to do too much sugary beverages. But again, if it's a fluid, I'd rather they have something than nothing. So she had a little bit of low citrate. So why would she have low citrate? It could be medication. It could be she doesn't ingest too many fruits and vegetables, which she didn't have too many listed there. She could have some acidosis. She could have just an imbalance in her diet, which her diet is a little off. So what I would counsel this patient, citrate is a molecule in the blood and the urine, and it binds to calcium. So when it binds to calcium, it kind of shields calcium from binding with oxalates and phosphates. So that's why it's really important, and that's why we stress the citrate consumption. So you want to increase your citrus naturally through fruits and vegetables, but in particular fruits like lemons, limes, melons, tomatoes, oranges. They give you those 5 give you the biggest boost of citric acid. You can get some from apples and pears and other fruits, but those 5 give you the biggest boost. So whether you eat them as fruit or juice them, it doesn't matter, but if you can get a couple servings a day of citrus, that would be beneficial. Lower your protein, your animal protein intake, and increase your fluids. And then if they have trouble just doing this, some people have, she's got acid reflux, and it does cause her some cold sore or some mouth sores when she drinks too much or consumes too much citrus. So potassium citrate or sodium bicarb would be medications you could try. So this is what I would recommend to her. We're going, because her pH is so high, so potassium citrate that she's currently on is an alkalinizer, and her pH is too high. She kind of fluctuates. She dips, she goes up and down and up and down. So we're going to just stop her potassium citrate at this point. She doesn't need to take her Flomax, Pyridium, Zofran anymore because the stone is passed. And then I would just stress the fluid for her, fluids, and I would recheck her urine in 6 months. So say you have a patient, they don't have time to do a 24-hour urine test, they're not interested in it, but you know, like they recently passed a stone, you know what their stone is. So you can give her some general guidelines. So these are some things that promote calcium oxalate and calcium phosphate stones. So urine, low urine volume, high calcium, high oxalate, high sodium, high uric acid, and low citrate. So you can give your patient some general guidelines on how to kind of adjust things in their diet so they can reduce those factors. And then factors that promote uric acid stones, again, low urine volume, high acid urine, and a high uric acid level. So again, just some general guidelines if people just don't have the time or don't want to do it, because it is an inconvenient test. You pretty much have to spend the day at home, or you're carrying around a jug, which is not convenient. Well, if more people are at home right now, you could probably get it done. But when people are back to work, it's a little difficult. So there's two more stones. I don't see a lot of cystine stones, but they are out there. So if you do encounter somebody who makes cystine stones, these are really tricky. This is a genetic condition. It's a homozygous recessive genes for cystine transport, and it produces an excessive urinary cystine. These patients are really, really tough to manage. So they have to be on a super, super strict, low sodium, a lot of times even less than 2,000 milligrams a day, reduce the animal proteins. What you want to do is try to alkalinize their urine. So normally you want somebody around a 6.2 pH, but for these cystinuria patients, you almost want it at 7. You want it like neutral. So reducing their animal proteins, increasing their citrates, lots of fluids. Certainly they probably should be closer to 3 liters. And then they're probably going to have to be on some medication like Thiola, copramine, captopril, potassium citrate, a lot of potassium citrate. So they, you just have to alkalinize. And then struvite stones, these are caused by urinary infections with urease producing organisms. Most common Proteus, less common is Klebsiella, Enterobacter, or Pseudomonas. You see these probably in older people who aren't emptying their bladder. They just get recurrent infections after infection. So the only way to fix this is to clean them out. So you have to remove all the stones, and then you have to figure out why they're not empty, what's the backup. And then sometimes they just have to be on suppressive antibiotics. And then certainly fluids. A lot of times older people aren't drinking as much because they just don't have the sensation, and they probably have leakage problems. And they don't want to, or it's hard for them to get up to go to the bathroom. So they're just really reducing how much they're consuming. So you do your best to encourage them to drink a lot of fluids. All right, so in summary, every year more than 500,000 Americans are admitted to the ER for kidney stone problems, accounting for over $2 billion a year in healthcare costs. So prevention or reduction in events is possible and vital for our healthcare system and for our patients. Here's some general tips. So again, if somebody just comes in one time, they have a stone, the stone's passed, you may never see them again. But here's just some general tips you can share with them. Exercise for everybody. It's good. We all need it. A lot of us, the morbid obesity in America is crazy. So exercise for everybody. Fluids, 8 to 10 10-ounce glasses of fluids a day, preferably water. Again, limiting your sodium. We have a lot of processed foods, and we can all use it, cutting back on the salt. And then encouraging to fresh lemons or limes, or 5 fruits and vegetables a day, which can take a lot of work, but you can do it. So something as simple as lemon or lime in your water, glass of lemonade. And then you want to encourage 2 to 3 servings of calcium per day. Again, people think they make stones, they can't have any calcium, but that's not true. They enjoy milk, they can have milk, but 2 to 3 servings of some calcium-rich foods a day. And there's other sources besides dairy out there. Okay, I want to thank Rachel and Dr. Manga again for the invitation to present today, and thank you all for joining us.
Thanks so much, Heidi. That was awesome. It was really informative, and I love the cases. So we already have some questions coming in. Everyone who's listening, go ahead and you can use the Q&A section if you have additional questions. All right, so beginning with our first. So this is a question from a Urogyne nurse practitioner. She
Okay.
asks, if I have a patient with an incidental finding of a non-obstructing stone on imaging, do they need to be referred to urology at that point? How do you counsel patients on incidental stones that aren't causing an issues?
Right. So if it's not, if there's no hydro, there's no pain, it's just there, you could certainly just monitor it. You could just do an ultrasound once a year if they're interested in that. You could just, yeah, there's really nothing you have to do if they're not having any symptoms. You can certainly just give them the general guidelines, fluids, citrus, watch your salt. Then that way it may curtail the growth of the stone. But yeah, you don't have to send them to a urologist for an incidental finding.
And correct me if you disagree, Heidi. I think it also sort of somewhat depends on the size of the stone too, and I don't think anybody would ever be faulted for referring just to check if you're not sure. I think that
Sure.
stones, you could follow and watch and not necessarily an issue. Sometimes the radiologist will say, non-obstructing stone, and it'll end up being, a centimeter. So I think there's
right. Yeah, that's true. You're right. Yeah, if it's less than 5 millimeters, I mean, they certainly have a chance of passing it on their own if it does decide to move. I mean, you can warn them what those things would feel like and when they should reach out to a provider. If it's bigger than 5, then, if they're interested in something, because between certain like 5 to 10 to 12, they could probably do a shock wave. Once it gets beyond that, then the success rate of a shock wave lithotripsy kind of declines, and then you're looking at a ureteroscopy or a percutaneous procedure. So, yeah, it depends on the size of it, certainly. Yeah. Thank you, Rachel.
And then another question is, how do you advise patients when on their UAs is resulted that they have crystals? So let's assume they've never had a stone or they've never had stone, but they show up with crystals. What do you say?
Yeah, we do get referrals for that, and people are very concerned about it. I mean, it's kind of a good thing that the crystals are coming out in the urine. So they're coming out, they're not building up. So you can just mention that if they're interested, you can get a scan to see if they do have anything in the kidneys. But you can give them the general guidelines, but it's better that they're coming out than building up inside.
And then you probably get this question a lot, Heidi. When we talk about probiotics for hyperoxaluria, is there any type that you particularly recommend?
Yeah, I get that a lot with supplements. Whatever the patient feels confident in. I don't have a particular brand that I push. Certainly, the higher level of probiotics, the better. But I don't have a specific brand.
And then can you speak at all to dosing, indication, and titrating for allopurinol?
Yeah, so I don't jump right to medications. But I guess it depends on the patient. If the patient is really motivated, I do give them a chance to work on their diet adjustments first before just putting them on medication. Now, if they have a serum, an elevated or a high serum uric acid and a high urine uric acid, I would start at 100. I usually start low and then progress from there. So I would start at 100 milligrams, check their liver functions 2 to 3 weeks later, and then check the urine, 24-hour urine in 3 months.
Okay.
In addition to them adjusting their diet. So, and then I would go up from there. So if the next test we get, if it's still elevated, then I would go to 200.
Cool.
So, I mean, you'd have to look at the patient too. If it's a morbidly obese patient, they're not that motivated, you may start at 200. You may have to go to 300. You'd get a gauge once you also do a little diet history. But usually I start out low.
Yes. All right. And then what about diet or sugar-free lemonade? Any thoughts on that?
Yeah, I mean, yeah, those are both fine. I'm not, a lot of people ask me about that too, because there's all that controversy about the fake sugars. But sugary beverages can increase your risk for stones. So like sweet tea is not good, but a regular tea, unsweetened tea would be a little bit better. So yeah, sugar-free lemonade would be, I think, better than a full of sugar lemonade.
There you go. And then Dr. Mongo wants to know when you're moving to San Diego.
Maybe once all my kids graduate.
Well, Heidi, this was super great. Thank you so much for joining us today. If there are any other questions, go ahead and submit them in the Q&A right before we end, and I will send them to Heidi personally so she can respond individually. Thanks everyone for joining us. Don't forget, you can review this recording if you want to go back and review anything that Heidi spoke about, or if you want to review any of our prior webinars, or if you happen to not be able to make one of our future webinars, go to our YouTube channel and search for our page, APP Symposium. You can also follow me on Twitter at EuroPA_SD, or you can follow UCSD Urology at UCSD Urology, and you will find the links posted for this webinar, for our recordings, and for all future registration links for upcoming recordings. If you like what you see, please also look out for the survey that we are going to be sending out to our registrants over the coming week to talk about what you've liked, what you'd like to see, where you've heard about us. So thank you so much for joining, and have a wonderful rest of your week.
Thank you.